Walk into any pharmacy or health food store, and you will find an entire wall dedicated to arthritis supplements. Dozens of products, hundreds of claims: glucosamine, chondroitin, collagen, turmeric, boswellia, MSM, fishbowl, vitamin D, vitamin C, magnesium, hyaluronic acid, each one promising to relieve joint pain, rebuild cartilage, reduce inflammation, and restore the mobility that arthritis has been stealing from you. And most of them, if we are being completely honest, have clinical evidence that ranges from modest to mixed to non-existent. But 3 of them do not. 3 specific vitamins and nutritional compounds have accumulated a clinical evidence base that is so consistent, so rigorously documented across multiple independent randomized controlled trials, and so specifically relevant to the biological mechanisms of arthritis pain and joint damage that calling them proven is not marketing language. It is the accurate description of what the peer-reviewed research actually shows. Today I am going to tell you exactly which 3 compounds those are. I am going to explain precisely why they work at the level of the molecular pathways and the joint biology, and I am going to show you exactly how the science says they should be used to produce the results that the research documents. Not the label dose, not the generic recommendation, the specific protocol that the clinical evidence supports. Before we get into the 3 compounds, if you have been following this arthritis series, and you want to make sure you never miss the next video, subscribe to this channel right now. Hit subscribe. We create this content specifically for you, and this channel exists because of you. Now let us start with a framework that makes the difference between proven and promising, because understanding what the standard of evidence is for these claims is what allows you to evaluate every arthritis supplement you will ever encounter from this point forward. When researchers want to establish whether a compound genuinely reduces arthritis pain or protects joint health, they conduct randomized controlled trials studies in which participants are randomly assigned to receive either the compound being tested or a placebo. When multiple independent research groups conduct these trials and consistently find the same results, and when those results are pooled in systematic reviews and meta-analyses, the evidence reaches a level of reliability that moves it from promising to proven. The 3 compounds I am about to describe each have multiple randomized controlled trials and at least 1 systematic review or meta-analysis documenting their effectiveness. They each have a clearly understood biological mechanism, and they each have a safety profile that makes them appropriate for long-term use in seniors. This is the standard. These 3 compounds meet it. The first proven arthritis vitamin is vitamin D, and the reason it earns this designation is not simply because of its well-known role in bone health, but because of its specific and documented role in the inflammatory biology of both osteoarthritis and rheumatoid arthritis that goes far beyond calcium absorption and bone mineralization. Vitamin D, specifically its biologically active form, calcitriol, is not simply a nutrient. It is a steroid hormone that binds to the vitamin D receptor. VD are expressed throughout the body, including in the synovial membrane of joints, the articular chondrocytes that maintain cartilage, and the immune cells that mediate joint inflammation in rheumatoid arthritis. The vitamin D receptor in chondrocytes regulates the production of the matrix metalloproteinase that degrade cartilage collagen when activated by inflammatory cytokines. When vitamin D levels are adequate, this regulation suppresses cartilage matrix degradation. When vitamin D is deficient, which in adults over 60 is the norm rather than the exception without supplementation, this protective regulation is absent, and the inflammatory degradation of cartilage proceeds unchecked. Research published in the journal Annals of the Rheumatic Diseases found that vitamin D deficiency was significantly associated with the progression of knee osteoarthritis in a longitudinal study of adults over 50, with those in the lowest vitamin D quartile showing significantly greater cartilage loss on MRI over the follow-up period than those in the highest quartile. A meta-analysis published in the European Journal of Clinical Nutrition found that vitamin D supplementation significantly reduced pain scores and improved physical function in adults with knee osteoarthritis across the pooled data from multiple randomized controlled trials. For rheumatoid arthritis specifically, calcitriol inhibits the differentiation and proliferation of the Th17 immune cells that drive the autoimmune attack on synovial tissue in rheumatoid arthritis, and promotes the regulatory T-cell population that suppresses this autoimmune activity. Research published in the journal Autoimmunity Reviews found that vitamin D deficiency was significantly more prevalent in rheumatoid arthritis patients than in healthy controls, and that the severity of vitamin D deficiency correlated with disease activity score. The seasonal and lifestyle dimension of vitamin D deficiency in adults over 60 compounds this problem in ways that are almost invisible to the people experiencing them. The skin's capacity to synthesize vitamin D from ultraviolet B radiation declines progressively with age, by some estimates reducing to approximately 25% of the synthesis capacity of a young adult by age 70. The conversion of the skin-produced vitamin D precursor to the biologically active calcitriol occurs in the liver and kidneys, both of which show reduced efficiency with advancing age. And the dietary contribution to vitamin D status is limited in most Western diets. Meaningful amounts found only in fatty fish, cod liver oil, egg yolks, and fortified dairy products. Supplementation is not optional for most adults over 60 who want to maintain the joint protective vitamin D levels the research supports. It is a biological necessity. The practical protocol: a daily vitamin D3 supplement, the form that raises serum vitamin D levels most efficiently, significantly more effective than vitamin D2 at a dose of 2,000 to 4,000 international units for most adults over 60, taken with a fat-containing meal for optimal absorption. The target serum level is 40 to 60 nanograms per milliliter, the range most consistently associated with optimal musculoskeletal outcomes in the research. If you have not had your vitamin D level tested in the past year, that blood test is the single most actionable first step in implementing this protocol. The second proven arthritis compound is omega-3 fatty acids, specifically the long-chain omega-3s EPA and DHA from marine sources, whose anti-inflammatory mechanisms and clinical evidence we have discussed across multiple videos in this series, but whose specific designation as a proven arthritis compound deserves the full mechanistic treatment here. EPA and DHA are specifically anti-inflammatory in the pathways most relevant to arthritis through three distinct and additive mechanisms. The first mechanism is competitive inhibition of the arachidonic acid pathway. EPA competes directly with arachidonic acid, the omega-6 fatty acid that is the primary substrate for inflammatory prostaglandins and leukotrienes in arthritic joints for the cyclooxygenase and lipoxygenase enzymes. When EPA is present in sufficient concentration in cell membrane phospholipids, it replaces arachidonic acid as the substrate, and the resulting EPA-derived icosanodes are significantly less inflammatory. This is the same pathway that NSAIDs like Celebrex, meloxicam, and naproxen target, but through substrate competition rather than enzyme inhibition, and without the cardiovascular, renal, and gastrointestinal risks. The second mechanism is the production of specialized pro-resolving mediators, the resolvins, protectins, and marsins that are derived from EPA and DHA, and that actively signal the resolution of inflammation rather than simply reducing its production. This distinction between reducing inflammation and resolving it is clinically important in chronic arthritis, where the inflammatory process fails to self-terminate and requires active resolution signaling to return to homeostasis. The third mechanism is the reduction of TNF-alpha and IL-1 beta, the primary inflammatory cytokines that drive cartilage destruction in osteoarthritis and synovial destruction in rheumatoid arthritis through NF-κB pathway modulation that adequate omega-3 status produces at the gene expression level. Research has documented that EPA and DHA suppress NF-κB activation in macrophages and synovial fibroblasts, the cell types responsible for producing these cytokines in arthritic joints. A meta-analysis published in the journal Pain analyzing data from 17 randomized controlled trials found that omega-3 supplementation produced significant reductions in joint pain intensity, morning stiffness, number of painful joints, and NSAID consumption in patients with inflammatory joint disease, with effects most pronounced at doses of 2 to 4 grams of combined EPA and DHA per day, and after 12 or more weeks of supplementation. Before we reveal the third proven compound, here is a pause specifically for you. Of the two compounds we have discussed so far, vitamin D and omega-3 fatty acids, which one are you already taking? And are you taking it at the dose the research supports? Drop a comment below right now and tell us. Knowing what this community is already doing helps us create the content that fills the gaps most effectively. We read every comment. The third proven arthritis compound is vitamin K, to specifically menaquinone 7, or MK7, the form of vitamin K2 with the longest half-life and the most complete clinical evidence. Its inclusion on this list represents the most surprising addition to the category of proven arthritis vitamins, because most people are entirely unaware that vitamin K exists in multiple forms with vastly different biological functions, and that K2's specific role in the musculoskeletal system makes it one of the most directly relevant vitamins for joint health in adults over 60. To understand vitamin K2's role in arthritis, you need to understand vitamin K-dependent proteins, a family of proteins whose biological activity depends on a post-translational modification called carboxylation, that is carried out only in the presence of adequate vitamin K. Several of these proteins are specifically expressed in joint tissue and bone, and their carboxylation status, which reflects vitamin K adequacy, determines whether they can perform their joint protective functions. Osteocalcin is a vitamin K-dependent protein produced by osteoblasts, bone-building cells, that when carboxylated binds calcium and directs it into the bone mineral matrix, maintaining bone density and the subchondral bone integrity that underlies cartilage health. When vitamin K2 is deficient and osteocalcin is undercarboxylated, a state measurable by the ratio of carboxylated to undercarboxylated osteocalcin in the blood, calcium is not efficiently directed into bone, and the subchondral bone that supports cartilage deteriorates in ways that accelerate cartilage degeneration. Matrix GLA protein MGP is the second vitamin K-dependent protein most directly relevant to arthritis. MGP is expressed in articular cartilage and inhibits the calcification of articular cartilage, the pathological deposition of calcium in cartilage tissue that is increasingly recognized as a driver of osteoarthritis severity. When vitamin K2 is deficient and MGP is undercarboxylated, cartilage calcification proceeds, contributing to the stiffness and pain that characterize advanced osteoarthritis. Research published in the journal Arthritis and Rheumatism found that low serum vitamin K levels were significantly associated with the prevalence and progression of hand and knee osteoarthritis in a large cohort study of adults over 50, with those in the lowest vitamin K quartile showing significantly higher rates of osteoarthritis presence and radiographic progression. A subsequent intervention trial published in the journal Osteoarthritis and Cartilage found that vitamin K supplementation in adults with low baseline levels produced significant improvements in cartilage quality measures on MRI and significant reductions in physical disability compared to placebo. The practical protocol: 100 to 200 micrograms of MK7 daily, taken with a fat-containing meal. MK7 is found naturally in highest concentrations in natto, the Japanese fermented soybean product, but the levels in typical Western diets are insufficient to maintain the carboxylated MGP and osteocalcin status associated with optimal joint outcomes. An important safety note: for anyone taking warfarin, vitamin K2 supplementation can interfere with warfarin's anticoagulant effect and should only be used under direct physician supervision with appropriate INR monitoring. For adults taking neurodirect oral anticoagulants apixaban, rivaroxaban, dabigatran, this interaction risk does not apply, but medical guidance is always appropriate before beginning any new supplement with active anticoagulation. The interaction between the three proven arthritis vitamins and specific rheumatoid arthritis medications deserves specific discussion. Vitamin D supplementation at the doses we recommended is not only safe alongside all standard rheumatoid arthritis medications, but is specifically recommended in clinical guidelines because of its dual effect of reducing joint inflammation and protecting bone density against corticosteroid-related bone loss. Several rheumatology society guidelines now recommend routine vitamin D monitoring and supplementation in all rheumatoid arthritis patients as a standard component of care. Omega-3 supplementation at 2 to 4 grams of EPA and DHA daily is compatible with all standard rheumatoid arthritis medications. Research published in the Annals of the Rheumatic Diseases specifically examined omega-3 supplementation in the context of methotrexate therapy and found that the combination produced greater improvements in disease activity scores and greater reductions in inflammatory biomarkers than methotrexate alone, suggesting that omega-3 acts synergistically with methotrexate rather than simply additively. The quality and purity standards for these three supplements are practically relevant. For vitamin D3, look for products carrying certification from independent testing organizations such as USP, NSF International, or Consumer Lab, which verify that the product contains the stated amount and is free from contaminants. For omega-3 fish oil, quality is more variable and more consequential. Fish oil is highly susceptible to oxidation that reduces both the EPA and DHA content and introduces potentially harmful oxidized lipid products. Choose molecularly distilled fish oil products purified to remove heavy metals and PCBs, and check that there is no strong rancid odor when the capsule is opened, a sign of oxidation. For vitamin K2, verify the MK7 form rather than MK4, which has a significantly shorter half-life and requires multiple daily doses to maintain the plasma levels that MK-7 single daily dose achieves. Now let us put all three together because the combination of vitamin D, omega-3 fatty acids, and vitamin K2 is synergistic, addressing complementary and non-overlapping dimensions of arthritis biology simultaneously. Vitamin D addresses the inflammatory regulation at the level of immune cells and chondrocyte gene expression. Omega-3 fatty acids address the inflammatory substrate and mediator production in the synovial membrane and joint fluid. Vitamin K2 addresses the structural integrity of the subchondral bone and the prevention of cartilage calcification. Together they cover the inflammatory, immunological, and structural dimensions of arthritis biology in a way that no single compound achieves. The practical daily protocol for all three: vitamin D3 2000 to 4000 international units with breakfast. Omega-3 EPA plus DHA to 2 grams combined with dinner for fat-soluble absorption. Vitamin K2 as MK7 100 to 200 micrograms with dinner alongside the omega-3. These three supplements address the most evidence-supported nutritional dimensions of arthritis management, simultaneously completing the nutritional foundation that the dietary strategies from our food videos build upon. The wall of arthritis supplements at the pharmacy will still be there tomorrow. Most of what is on it will still have evidence that ranges from modest to mixed to non-existent. But now you know which three: vitamin D3, omega-3 EPA and DHA, and vitamin K2 as MK7 have earned the word proven. You know why they work at the level of the molecules and the joint biology. You know exactly how to take them. And you know what to look for on the label to make sure you are getting the form and dose the research supports. 3 vitamins, 3 mechanisms, 1 protocol. The most evidence-supported nutritional foundation for arthritis management that the current research provides. The evidence landscape for vitamin D in arthritis management has evolved significantly in the past decade, and the nuances of this evolution deserve honest acknowledgement. Because the story is more complex than a simple endorsement, and the complexity is precisely what makes an informed approach to vitamin D supplementation more effective than a blanket one. The early observational studies on vitamin D and osteoarthritis progression, which documented the strong association between low vitamin D levels and faster cartilage loss, generated enormous enthusiasm for vitamin D supplementation as a disease-modifying intervention in osteoarthritis. Several large randomized controlled trials subsequently tested whether vitamin D supplementation could slow osteoarthritis progression, and the results were more modest than the observational data had suggested, with some trials showing significant symptom benefits and others showing less pronounced structural effects on cartilage volume. The current consensus interpretation of this evidence is nuanced. Vitamin D supplementation appears most effective in adults who are genuinely deficient at baseline with serum levels below 20 nanograms per milliliter, and less dramatically effective in adults who are already in the insufficient or low normal range. This dose-response relationship is why measuring your baseline vitamin D level before supplementing is the most intelligent approach. It allows the dose to be calibrated to the degree of deficiency, rather than applying a fixed dose regardless of baseline status. For rheumatoid arthritis, the evidence for vitamin D is more consistently favorable across trial designs, likely because the immunomodulatory VD are mediated effects on Th17 suppression and regulatory T-cell promotion represent a direct mechanistic intervention in the autoimmune pathology of the disease, an intervention that is most impactful when the vitamin D receptor has an adequate ligand available to activate it. Several international rheumatology societies now explicitly recommend vitamin D supplementation as a standard adjunct to disease-modifying therapy in rheumatoid arthritis, not as a replacement for pharmaceutical management but as a genuine biological modifier of the disease process. The omega-3 story similarly has nuances that make the informed approach more effective than the generic one. The clinical trials that showed the strongest anti-arthritis effects of omega-3 supplementation were predominantly conducted in adults with rheumatoid arthritis and in adults with high baseline omega-6 to omega-3 ratios, meaning high arachidonic acid membrane content and high baseline dietary omega-6 intake. The mechanism explains this. The competitive inhibition of the arachidonic acid pathway by EPA is most pronounced when there is the most arachidonic acid to compete with. Adults who have already reduced their omega-6 intake by switching from vegetable oils to olive oil, by reducing ultra-processed food consumption, by eating the anti-inflammatory diet we described in our food videos, have already shifted their omega-6 to omega-3 ratio toward balance. And the incremental benefit of additional omega-3 supplementation builds on that dietary foundation rather than working against a flood of competing arachidonic acid. This integration dietary omega-6 reduction combined with omega-3 supplementation produces a synergistic shift in the membrane fatty acid profile that is more complete and more sustained than supplementation alone. And it is the specific combination that the research on the Mediterranean dietary pattern, the most extensively studied anti-inflammatory diet in the world, suggests produces the most robust reductions in arthritis disease activity markers. For vitamin K2, the evidence landscape is the most recently developed of the three, and the most rapidly evolving. Research into MGP carboxylation status measure by the desphospho-uncarboxylated MGP level in blood, a relatively new biomarker of vitamin K to tissue adequacy, has revealed that a significant proportion of adults, even those not obviously vitamin K deficient by older assay methods, have subclinical vitamin K2 insufficiency at the tissue level that impairs MGP function without producing frank deficiency symptoms. This subclinical insufficiency is most prevalent in adults over 60 because vitamin K2 absorption from dietary sources declines with age and because the Western diet is systematically low in MK7 relative to the MK4 form, and it represents a broader prevalence of vitamin K2 inadequacy than previously recognized. The clinical implication is that vitamin K2 supplementation at 100 to 200 micrograms of MK7 daily may benefit a substantially larger proportion of adults over 60 than those with frank vitamin K deficiency, specifically those with subclinical insufficiency, whose MGP and osteocalcin carboxylation is impaired despite apparently normal vitamin K blood levels. The desphospho-uncarboxylated MGP assay is not yet routinely available in standard clinical practice, but its emergence as a research tool has clarified the breadth of the population for whom vitamin K2 supplementation is likely to produce meaningful joint protective benefits. The daily 3 supplement protocol that integrates all of this evidence: vitamin D3 2000 to 4000 international units at breakfast, omega-3 EPA and DHA 2 to 4 grams at dinner, vitamin K2 as MK7 100 to 200 micrograms at dinner alongside the omega-3, represents the nutritional completion of the comprehensive arthritis management approach we have built across this entire video series. Each supplement addresses a dimension of arthritis biology that the others do not: the inflammatory gene regulation of vitamin D, the substrate competition and resolution signaling of omega-3, the structural bone and cartilage calcification protection of vitamin K2, and together they create a daily biochemical environment in which arthritic joints have the most complete nutritional support the evidence currently offers. The investment required, financially modest, logistically simple, and scientifically justified, is the daily discipline of taking 3 supplements whose mechanisms are understood, whose clinical evidence is documented, and whose safety profiles make them appropriate for the long-term use that chronic arthritis management requires. That daily discipline, sustained over months and years, is what transforms the promising research on these 3 compounds into the lived experience of less pain, better function, and slower joint deterioration that the research documents. These are the 3 that work. Now use them. If this video completed the arthritis series in a way that leaves you with a specific, evidence-based nutritional protocol you can implement this week, please support this channel. Hit the like button right now. Subscribe if you have not already. Share this video with someone who is managing arthritis and spending money on supplements that may not be earning their place in the routine. And leave a comment below. Tell us which of the 3 vitamins you are going to add first, or tell us which one surprised you most. We read every comment. Your engagement is what makes this channel possible. Thank you so much for watching. See you in the next one.